Hello, everybody. I am so excited about today's presentation. So prior to COVID, we really didn't feel like we had a really good format for doing um, technique presentations in a webinar. But what we found out in a post-COVID world is that we absolutely did when we transitioned into virtual conferences. And in fact, what we found out in the feedback that we were getting at those events from attendees was that they were able to better see the techniques that were being demonstrated in that virtual atmosphere versus having to see a presenter on stage try to demonstrate it. So I worked with Dr. Wong, and he and I have been friends for many, many years. And it took me a couple of months to convince him that we could actually do this and it would be very effective. And I'm not even going to lie, I called in some help from my dear friend, Dr. Mark Charette, to help me in convincing him that this was an excellent idea. And he's one of my favorite adjusters. And so I'm so excited that we were able to convince him to do this. And we had so much fun putting this presentation together. So if you have never seen Dr. Wong speak at your association or a national event, he is a licensed chiropractor for over 24 years in Walnut Creek, which is just east of the San Francisco Bay Area. He is a graduate of Palmer College West, and he has been teaching technique for foot levelers for years and years and years. I mean, as long as I have been involved in chiropractic, which is almost 11 years. He was also nominated Best of the Bay in the chiropractic category, and he is just the most amazing and delightful person ever. I always joke, or I just recently told him that I just get so much when I talk to him, but being around him in person, you just feel his love and enthusiasm for the chiropractic profession. And so y'all are really, this is like such a treat to have him here today. And Dr. Tom, don't worry about it. If something happens, I'm fingers crossed that you don't miss out on any of this presentation, but just know that this presentation is recorded. You will all have access to the recording. It's automatically sent to you in about 2 hours. And so you don't have to request it. Feel free to share it. You can also look it up on our website at ChiroHealthUSA.com/webinars, where we have an amazing lineup for the rest of this month. Got some exciting news coming too about the webinar series. But you can just click on archived webinars and find your favorite speakers and the topics that they cover at any time. So, and just a reminder, we do not have any handouts for today's presentation because it's kind of hard to do handouts for techniques. So without further ado, here is Dr. Wong.
All right, hello everybody. I want to welcome you to my little webinar, and I want to thank Christy and ChiroHealthUSA for inviting me as their guest. It's so exciting. I love Christy, so it's fun to get to work together, the two of us. Now, when we were brainstorming ideas, we came up with this part of the body because, as many of you know who have seen me before, I really love specializing in treating extremities, but especially the extremities that I feel like we really never got great training with when we were going through school. I know feet and TMJ and shoulders, like shoulders and ribs are a big part of daily practice, and I know you know this. So we're going to go through. My intent here is not to make you change what you're doing, but enhance what you're doing already and give you more ideas for what you can do. And I'm just excited about this because I've got some new material in here that I haven't been able to show people before. So we're going to just move through this together and we can see what you think about it as we get through. All right. So in a nutshell, because we don't have a lot of time, that's me. This is who I am these days, where I went to school. I'm a really proud member of my state California Chiropractic Association. And I've been with Foot Levelers since 2004 as a major speaker. In fact, that's kind of how I met Christy. In the first place, is just being a speaker for Foot Levelers. I've seen her a lot of seminars and we've become friends over the years. And I do a lot of work with rock tape. I've done more in the past, but it's just now a lot of my teaching just comes through Foot Levelers and it takes a lot of my time. So there's me. And there's Grogu's Baby Yoda. Okay, yeah, that's a grown 50-year-old man you're seeing there with a stuffed animal on his lap. But hey, Okay, let me first make sure you understand that a lot of my work comes from the ground up. We're not going to be talking about the feet here, but do realize that your arches of your feet, there are 3 of them, and they really help to determine a lot of stability in the rest of your body, all right? They can have a contributory factor to your shoulders. We're just not going to be talking about them very much this time, all right? So let's move along here. I'm going to jump right into the shoulder. All right, take a deep breath with me. Take a deep breath because I want you to really be focused on this. If you are doing something else right now and you just have this on in the background and you're trying to just get your CEs while you clean your house or make dinner, then just focus with me for a little bit, because I want to really make you very, very skilled at this area. Because I will tell you now that many of our brothers and sisters in chiropractic have not had a lot of training on the shoulders. We get the cursory knowledge of learning anatomy in school, but we don't know in depth how to address all of these joints. And it's really important for you to know this, because a lot of people's shoulders don't hurt them, but they wreak havoc on the neck and upper back. And if you're not looking for this, you will miss it, as I have missed it in the past. And you will have patients that you seem to adjust their spine pretty nicely and you get a pretty clean set, but it seems to come back, the pain seems to come back on them. So let's just kind of look at the shoulders and see what your thoughts are and your experiences at this point. There's the shoulder girdle. There on the left side of the picture, you can see the front portion of there with the sternum, and on the right side, you can see the back portion. The shoulder is an amazing structure. It's the most mobile but least stable set of joints that we have in the human body, all right? So again, there's our anatomy. And I know many of you have memorized this in the past, and you probably still have it in your mind right now because there aren't a ton of shoulder bones. There's just so many of them, okay? But there's our upper extremity. And just remember, your hands can be affected by the shoulders. Your elbows can be affected by the shoulders. The shoulders can affect themselves, and the shoulders can affect the neck and upper back. Why do I say this? Because again, it's easy to miss these if you don't know what you're looking for and you don't have a way and a pattern of how to go about doing this, all right? All right, now, look at this picture again. We're gonna start dissecting this anatomy because I want you to be experts at this. Look at your clavicle, your AC joint, your acromion process coming from the scapula itself, the humerus and the humeral head fitting into the glenoid fossa. Look at that picture of it retracted, cut and retracted out. It's really interesting to see how narrow and how not very deep that socket is. That's why this joint becomes so unstable for people, is because they don't have a very deep ball and socket joint like your hip bone. Your hip joint is way more stable than this thing. This is why this is one of the places in the body where we see the importance of the rotator cuff muscles having to come into play to give secondary support for the shoulder, and why there are so many problems with those rotator cuff muscles. All right. All right. So there's our bones and there's our shoulder. Now I want you to look at these muscles. Look at them. You really should know these very well, my friends. Later scapula, supraspinatus, infraspinatus, rhomboids. All right, teres major, teres minor. You remember the rotator cuff is 4 muscles. You also remember that seeing all these muscles that are relayed back here, of the ones that are the most important one for you to realize is the trapezius. The trapezius, you know, the last time somebody pointed to this area when they came into your clinic, and they point to that area all day and they call it the shoulder. Well, you and I both know it's not the shoulder, but that's as limited in their knowledge as they have. So teach them well. The trapezius will always give you a hint as to if the shoulder is out of alignment or not, because it's one of the prime muscles that spasm when the shoulder joints go out of alignment, all right? So that's one big thing for you to pick up on. The trapezius muscle spasm that you could very well be feeling on yourself now that you're sitting here listening to me, it could be because your shoulder joints are out of alignment and they're pulling on your traps, all right? Because the patients have this so frequently that I treat a lot of shoulders in my practice. And That's because there's so many people that have this issue. Now, look at the other pictures. There's the deltoids. All right, you got your deltoids right on the tip of your shoulder, anterior, lateral, and medial. Anterior, medial, and posterior. All right, you have some of your pectoralis muscles. All right, there's a good picture of your traps. How many of you can remember the last time a patient came in and said that they had pain going from their neck all the way down to their mid-back? That trapezius muscle gets so activated by the shoulder joints being out of alignment that you can have pain all over there. And it really fools a lot of us chiropractors, because when we go and we see that there's pain in those areas, we almost always go for the muscle work, and then we always go for the adjustment, which is great. But don't forget, those shoulders are laughing at us when we miss them. They said you just went for the fake, all right? I am out of alignment in multiple areas, but you are just getting the trapezius and the neck and upper back. I'm going to pull them back out again by the time that this person comes back into you, all right? Another couple of days, I'll pull those back out again, so you have to fix them again when they do their follow-up visit, all right? And they can go down to the mid-back, and they can pull out ribs and stuff like that too. So there are the players of our shoulder girdle. SC, scapulothoracic, or acromioclavicular, and glenohumeral. You know these names well because you have memorized these however many years ago that it took when you were in chiropractic school, all right? But remember, these guys they all work in the same gang. They all work together to throw out the stability of the shoulder. Now let's take these piece by piece. Let's look at glenohumeral. That is your biggest ball and socket. Synovial ball and socket articulation. There's hyaline cartilage in there, and the joint stability is really provided by your rotator cuff, your long head of the biceps, and some of your extracapsular ligaments. This is really important for you guys to remember, because the shoulder coming out of alignment and being able to be palpated at your glenohumeral joint is one of the most obvious things that we will ever find when a patient comes into us and they're looking for help. In fact, you, the chiropractor, often can just have a patient sitting in front of you and you just go and grab them like this and put your hands over their shoulders, and you can feel those humeral heads shifted forwards when they're out of alignment. It's really, really amazing, and it's very obvious and very common and frequent for you to be able to find this. The movement of the shoulder is all 6 degrees of range of motion, including circumduction, all right? It goes everywhere. That joint is the most mobile, least stable, and anything that mobile has got to have some problems with stability at some point down the road, all right? Now, the misalignment for the glenohumeral joint is for the humeral head to go anterior inferior. You're going to find this almost always on patients, especially in an insidious or non-traumatic onset or a repetitive stress onset. We are all seeing patients that are working from home, or they're working at their computer, or they're sleeping on their side at night, which is another terrible thing people do to throw their shoulders out of alignment. So when they are doing these activities, like you are now sitting listening to me on your computer, we tend to roll our shoulders forwards. And because people still aren't perfectly ergonomically set up in their desk, when they're reaching, they also are throwing their shoulders in a forward position. You'll almost always see your patients when they sit there forward like this, okay? It's really common in you because you see this. I'm not telling you something you don't already know, all right? All right, now, but it's going to go AI humerus versus posterior, or more commonly than a posterior. You'll see a posterior humerus when there has been an A to P blow or blunt trauma, or they fall on themselves front to back. That's when it will get pushed back a little bit. I just don't find these very often, all right? Now the clavicle. There's your clavicle, there's your sternal end or the medial end, and then there's the lateral end, all right, where it articulates with your acromion process. All right, the thing I care about that about the clavicle is that it actually does shift out of alignment. Remember, we've got that whole thing of how it kind of rotates or it nutates in there. But you take your fingers right now in your own clavicle area. Just do this, my friends. Take your fingers in here and kind of dig it in. Most of you guys, a lot of you watching this with me now, your shoulders are out of alignment. And I think you probably realize that. But when you get in here with like your clavicle, it's really sore in there. What am I doing? I'm digging my fingers in and I'm pulling P to A. All right, I'm pulling, so I'm decompressing the clavicle in there, and I can feel how sore that is. My right one is shifted on me right now too. So, okay, so that's the clavicle at the sternal end and the acromial and the AC and the SC joints. That's what we're dealing with. So there's your AC. And quite honestly, you have memorized these in the past. We have our coracoaclavicular ligaments, our coracoacromial ligaments, the acromioclavicular ligament, all those sitting in here. If one of more of those rips or tears, that's what allows you to have the separated shoulder, all right? That's what allows you to have that. We have separations at the AC. We have dislocations at the glenohumeral, all right? Okay, so let's look at the AC joint a little bit. Now, quite simply, I always want you to learn the way that these bones subluxate or misalign, because then if you've got the pattern down in your brain, you will know how to fix it every time. 95%, 98% of these patients are going to have these kinds of listings. Remember, like I told you, someone that's going to have a posterior humerus, they're going to have a reason. They're going to tell you, oh, I was running and I whacked into a wall, or somebody ran into me, all right? There's going to be a reason for an insidious onset shoulder pain that's chronic, that they've gone to the MD, PT, PYT, YMCA for. They're going to have this misalignment pattern that I'm teaching you right now. It's an AI humerus. It's a superior distal clavicle at the AC joint, okay? This is how it moves. It just pops up when it subluxates. There's the SC. Look at all those ligaments in there. The SC joint is fairly stable. It can misalign, but it really shouldn't have much more damage to it because it takes a lot of force to damage the SC joint, all right? Look, that tearing of the cartilage there, or the ligament, that's not a good thing when you see a sternoclavicular joint dislocation, all right? I throw that out there as a worst case scenario, but I don't see that very often. They certainly don't usually come to us when they have something like that done. They go right to the MD, all right? But with the SC joint, this is the only weird one that I'm gonna have you memorize, okay? I want you to take your index fingers and pretend that these are the clavicles right here, and it's your SC joint. What I want you to do now is to close your eyes and just listen to my voice when I tell you. Take the tip of your finger, that is the tip of your clavicle, as it meets the sternum. This is your SC joint. Now I want you to take the tip of your finger and go, move it superior, anterior, and medial. That's the way it misaligned when we memorized this years ago. It goes SAM, superior, anterior, medial. Now, when I push this back into alignment, I'm going to go posterior, inferior, lateral, or a 45-degree angle across your chest like this. So you go SAM to pill. That should seem familiar to you because I think we all memorized this years and years ago when we didn't really know what the heck this meant, all right? But now I see what it means because I do this all day on a lot of people. So we're going to be adjusting SAM to pill, all right? Now, look at your scapula. Look at if we were together, I'd be having you palpate all of these things. So I'm just going to trust that you're going to do that on yourself, because when you palpate yourself and you learn about your own body, it helps you learn about your patients, and it gives you a lot more sympathy when you feel how sore you are all over the place in here, all right? Now, there's our superior border, medial, lateral border. Remember, we've got a lot of rotator cuff muscles sitting on the scapula. So when you actually palpate this in a patient, and even on yourself, it gets tender. My infraspinatus are tender right now. All right, my teres minor is tender right now. Supraspinatus not so bad, but and there's there's the anterior view and then the posterior view where we see the posterior scapular spine. That spine that helps you demarcate where the supraspinatus and the infraspinous notches are. All right, and then we look at the scapula from that medial portion. You can see the glenoid fossa, how that shallow part where your humeral head goes into, all right? I just want you to be aware of this because it's a it's a musculotendinous joint. So it's just kind of hanging out on top of the rib cage, connected by connective tissue. And the shoulder blade has a lot of different motions. You can see, again, by the graphic, it reminds you the elevation, depression, adduction, abduction, upward rotation, and downward rotation, all right? It does a lot. And in fact, we have taken classes before where we look and see how these things move when people are raising and bringing down their arms, and we can see how it might get hung up. All right. For the most part, I find that these scapulae get stuck on the external rotation portion. They get kind of hung up there. All right. That's just what I observe on a lot of these patients. And then again, there's the rotator cuff. We recall that there are only 4, of which biceps brachii is not one of them. And you know that. I know you do. It's just that your patients don't. And they also have all kinds of colorful names for this area, like the rotary cup, the rotatory cup. I mean, they call it all kinds of things. So just teach your patients. They're smart people. Our patients are smart. So just teach them the right words so that they can speak with intelligence. You know, I just want people to be educated. Now, the misalignment pattern, as I mentioned before, it's a rotational pattern. I find it more external versus internal. All right. All right. Now, let's look at our ribs and our thoracic cage. You can probably remember the last time you had a rib out of alignment on yourself. I still have one right here. I've been working on for a couple of days. It can be a very, very sharp pain in the area of the rib. Now, we know what those are because we deal with them so much during the day. Remember, there are patients out there who have no idea that a rib can subluxate or misalign. And for that matter, a lot of the other types of healthcare practitioners don't realize it either. So a patient may not even know it's a rib until they come into your office and you tell them that they have a rib out. And they're like, what? What does that even mean? What does that mean? And you're like, oh, okay, sorry. Let me speak more in less colloquial terms. That means a rib is moved out of alignment. All right. Ribs have a narrow range of motion, my friends. 5 to 7 degrees up or down. What is the most common way that a rib is going to subluxate? I want you to think about that, okay? Because I'm going to ask you again in a little bit, all right? But look at your cage. You got 7 true ribs, 3 false ribs, 2 floating ribs. We can adjust all of them, but we can't adjust all of them in the front, but we can usually get all of them in the back, all right? Even 11 and 12, all right? Now, there's another picture of the rib cage in the front. I really want you to be familiar. If you are not actively treating ribs in your practice on a daily basis, then I want to open your eyes to it. Those of you that are treating the thoracic spine, by default, you are treating ribs because ribs are connected to the thoracic spine. But I want you to be better than that. I don't like that old saying better lucky than good. Okay? Be good and lucky. All right? That's what I want you to be here. Now, here is the rib alignment, or I'm sorry, the rib anatomy. Ribs go, you can see on the right side of the picture there. I really love, it's almost like a Lego, the way that the rib fits in to the vertebral body below and the picture below. It kind of just notches on there. It's kind of cool how it works like that. But remember, it doesn't snap in. I would argue that Legos are more stable than rib joints sometimes, because those ribs, when they pop out, holy smokes, they hurt. And they take a while to go away. This is not something where the patient's going to come in there. They may feel a little bit better, but they're going to feel sore all day after getting a rib back in. All right. So here are some of the things that we know about, that we hear about the ribs, that we see as practitioners. Okay. Ribs do go out of alignment regularly. In fact, you have some out on you right now, whether you know it or not. And I'm not saying that to be a jerk. I'm just saying that it's anatomical. We use our arms and our bodies all day to fix people. We're going to throw ribs out on ourselves, all right? Ribs rarely go back without any help. You know as well as I do that is a true statement. I know you have figured out when you've had a rib out, you've tried to fix it yourself. And if you don't have anybody in the office with you, you've done all kinds of weird, wacky things to put your ribs back in. It's really hard to get these to go back in without having somebody to adjust them. All right. Honestly, that's just, and then maybe it's good for us because we're the ones who know how to do this, but it's really frustrating when you get one out and it's the morning and you've got your whole day of patients ahead of you that you're trying to treat. Okay. It's really frustrating and very painful. When ribs go out, you may or may not notice them. Yes, there are some latent trigger points on the rib heads. Like as you sit there now and you're poking around on yourself, you could probably feel, ooh, wow. Look at that. That's really, really sore in there. Yeah, we're just the same as our patients. All right, we're just the same as the patients. Now, why do ribs go out of alignment? I will be very, very plain with you as I'm plain with my patients. These are what offend the ribs: twisting, bending, reaching, especially twisting and reaching, like when you're going to reach to the back of the car, okay? Sleeping on your side at night, which is what a majority of human beings in the world do. Many, many, many of you sleep on your side, and that is not good for the ribs. It's also not good for your hips, your TMJ, your lower backs sometimes, okay? But we're trying to stick to the ribs and shoulders. So what's the most common direction ribs go out of alignment? They subluxate 90% of the time superior. You get in there and you dig around, you can feel the superior way. I'm not saying can't go inferior. I just don't find them that way very often at all right? You may find differently, and that's okay. Location and quality of pain. They're usually localized, but if you get a rib that's out enough, it will shoot through the chest. And if they have a rib on the left that is shooting through their chest, many of your patients have ended up at the ER before, thinking that they are having a heart attack. And once they finally get all cleared from that and everything's all good, and they come to you, you teach them that it's a rib. So now they come to you first before they waste their time going to the emergency room and subsequently satisfying the deductible for the next 5 years from one visit to the ER, okay? So just know that, okay? Worse and better. People that have ribs out of alignment, they are going to be, it's hard for them to straighten up. They like to hunch down because that takes pressure off those intercostal muscles between the ribs. Those muscles spasm when ribs are out of place, and they create a lot of pain by clamping down on the intercostal nerve, all right? So they like to hunch forward. They like to take shallow breaths. They don't like to move very much because they're in pain, all right? So that's kind of how they do it. They don't like to they don't like to laugh or cough or sneeze because it really, really hurts, all right? Now, some of the treatment that we're going to get into now, aside from the adjusting, is remember that there are plenty of physiotherapy modalities that you've been exposed to, whether we have cold laser or we do stim or EMS or whatever, all right? Vibrations. Just think about what you want to do and use those modalities accordingly, depending on how bad the rib is or how bad their misalignment of their shoulder is. The more acute it is, the more swelling is going to be there. So you've got to take that into account. All right, we've got some adjustments that we're going to go over in depth. We're going to use some rib taping. This picture on here, on the left and on the right, are very common tape jobs I use for the rock tape or for your elastic tape. All right, they're very, very common. The one on the center, on the right there, where there's two vertical strips coming down, that is also the thoracic stabilization tape job. But if I have ribs on the right or left side, I can use a single piece of tape like that and stabilize the ribs, all right? And it's really great for rib heads, all right? It works very well, right? And of course, there's shoulder rehabilitation exercises that we can talk about, all right? Now think about this. These are the major players that you hear about from a patient that comes to your office after they've gone somewhere else to have their shoulder looked at. Chiropractors are not the first thought for many of these people when they have a shoulder problem. They're going to go to the real doctor that they say to us, the regular doctor, okay? And they're going to go there and they're going to get some kind of diagnosis, which is honestly the best guess. So you know as well as I do these conditions: dislocation, separation, tendonitis, bursitis, capsulitis, impingement, rotator cuff, tears, labrum tears, frozen shoulder, arthritis. Okay, we've seen these. So what do we do? What can we as chiropractors understand about these? And how can we help people in a way different way than any of the other providers that are out there? First of all, if someone's got a dislocation, odds are they're not going to be showing up to your office when it's an active dislocation, because they're going to be in such intense pain that their friends or them are probably going to take them to the ER, where they're going to have that put back if it's not already gone back, all right? More likely to have an anterior dislocation based on anatomy and musculature. A posterior dislocation is usually traumatic. Well, I'm sorry, they're both traumatic, but the way that things work is the mechanism of injury and the direction of the force, okay? The anterior dislocations are just way more common than posterior, right? There's a picture of a person calmly sitting there with their shoulder dislocated And I think you can guess which one it is, all right? And it's really sticking out on you. And look at the x-ray. That is not where the humeral head is supposed to be, all right? It's supposed to be a little bit north of that, where it's hanging out right now, all right? First of all, I'm surprised this guy is calm enough to be able to have a picture taken, because it's very intense pain. I've had it on my right shoulder before, and it wasn't very fun, all right? Now, shoulder separation, we alluded to this before. There are the different ligaments that can be torn. The more tearing you have, the worse the separation, all right? That's the worse it is. So, all the way up to, we have different grades and types, and some books will have all the way up to type 5, some have up to type 3. Just realize that the more that you have torn there, and the higher the clavicle goes up, the more likely you're going to have a higher grade of a tear, all right? Then tendonitis. When we talk about shoulder tendonitis, we really are talking about the biceps. And it's the long head of the biceps. And remember that we can have tendonitis on either of those heads as they're coming up through the top of the shoulder, all right? It's really, really common for people to have pain right in the front there where the biceps is, or where the biceps are. And what's so interesting about this is when people's shoulders are out of alignment, the humeral head has come forward and it's popped up the AC a little bit into misalignment here. Shoulder tendonitis is a common thing that people will find, but they don't realize that their shoulders are out of alignment as well. All right, that's where we come in. But yeah, shoulder tendonitis tends to be one of the more common things that you will see. Now, bursitis. Look at all the different bursa you have in the shoulder. We know that there are going to be quite a few there because the shoulder is very movable. And the more movable a joint, the more bursa they're going to have. You have a lot of bursa in the hip too, kind of like the shoulder, but you have a lot of these bursa right in the shoulder. And you can see the different names from subacromial, subdeltoid, the subscapular, subcoracoid. So they're all there to act as shock absorbers for all these tendons to move back and forth while the shoulder does its very complex motions. So bursitis is simply an inflammation or irritation of the bursa, one or more, all right? So as we go through these problems with the shoulder, I want you to remember something. They have a unifying theme, and that is that all these people, they are going to be out of alignment. They're going to be out of alignment in their shoulder. You're going to be the one to catch it because the PTs don't look for this stuff. The MDs don't look, and even in the shoulder orthos do not look for this stuff the way we look for it, all right? They're all smart in their own way, but you and I, we look at biomechanics. We look at movement patterns, and we look at the way a bone in a joint is stuck and not moving correctly, and we restore that motion. So when the joints are out of alignment, glenohumeral, AC, SC, scapulothoracic ribs, they contribute to global reduction of movement in the shoulder. And you are the one who can find this and restore that rather gently. It does not take a lot of force to do this. I don't use a lot of force in a lot of these patients. You'll see that soon, all right? Now, this in this case, we have impingement syndrome. It's one of the most common shoulder problems that the MDs will find and the orthos will find. When the arm is abducted past 90, the greater tuberosity of the humerus will compress the rotator cuff tendons against the acromion process, and it will cause pain and decreased motion of the shoulder. Remember, this is the one where the roof and the floor come together and they squish the things that are in between there. And that happens to be the rotator cuff tendons, all right? Again, misalignment of the shoulder. Get in there. Shoulder impingement can be external or internal. We see external impingements very, very commonly, all right? That's where the rotator cuff tendons are compressed by the acromion process, like we just said. The internal impingements are structures within the glenohumeral joint themselves that get impinged, all right? But again, joint instability will cause this. If the person's arms and shoulders are out of alignment for too long, they can lead to problems that the other types of medical professionals diagnose as one of the names that we just went over. So I care that someone has tendonitis. I care if they have this or that, but I also know that I got to get in and I've got to adjust the shoulder. to try to get better movement and alignment, and then that will help them with the named condition that they have. Now, the supraspinatus tendon, the biceps tendon, the subacromial bursa are all irritated and inflamed as they pass through the subacromial space. The medical types will tend to blame impingement syndrome on these things that you're seeing in black right on this page: subacromial spurs, AC joint spurs, and it very well could be some of those things, okay? But don't forget that some of these things are there because their shoulder's unstable because it's out of alignment for you to fix or for you to work on. Same thing with frozen shoulder. Any shoulder problem can end up becoming a frozen shoulder, or what we will call adhesive capsulitis, all right? It's when you have an inflammation, scarring, thickening, and shrinking of the capsule that surrounds the normal shoulder. Any injury can lead to this, including tendonitis, bursitis, and rotator cuff strains, all right? So just know that if someone has a frozen shoulder, don't go, oh man. Well, you can say that, but don't lose hope, because you are the person that can get in there and start adjusting them, all right? There's some pictures of the nasty tissue that is there when frozen shoulder is existing. We are aware of the fact that the medical doctors often will say, well, if you want a quicker pathway to relieving you of the frozen shoulder and you don't want to wait anywhere from 12 to 16 months for it to self-remit, I can put you under, I can take your arm, and I can forcefully bring it above your head and rip all of the soft tissue, then bring it down and it can re-heal again, all right? So that's one way of them rip all that tissue off and make it heal up again quicker, okay? One of the few places I show some the arthroscope images, but you can see there's a normal shoulder lining on the left, and then there's an inflamed shoulder lining on the right, just to tell you how haphazard and kind of weird that tissue is when it's placed down on a frozen shoulder. It's just non-functional tissue. Okay, labrum tears have become, they're always pretty popular, especially with certain sports that you will treat in your office. Really anything that involves the shoulder, but especially baseball, and especially tennis, all right, especially volleyball, you know, those types of things where you're really doing a lot of overhead work. And then some basketball players will see stuff. But remember, the labrum, believe it or not, is it's an extension of the biceps tendon. And it forms a little bit of extra cup around the glenoid fossa to try to suck that shoulder in there and make it a little more stable. But because it's so unstable, and because the shoulder goes through so much stress, and it's easy for it to get irritated, we can have degenerative fraying, tearing, and separating of the superior glenoid labrum. And that is especially in overhead or throwing activities, okay? So there's a couple words here with bucket handle tears and Bankart lesions and stuff like that, but this is what I want you to see. This picture is awesome because it totally shows us what the heck those words mean. Now look at this picture on the left side first, and you can see that we've got a front and a back of this labrum, okay? We're looking at it. The Bankart lesion, we have memorized that from years ago, and I always wondered why they called it this, and it's named after somebody. I mean, I'm sure their mother is proud. You'd never really know that, but it's a Bankart tear, a bony Bankart tear. It's present in of anterior dislocations. It's the front of it that gets torn, all right? And it kind of pooches out like that. Look at the posterior labrum tear, all right? 10 to 20% of some of athletes will tend to show a posterior labral tear. Then there's the slap tear. Now we know that the term or the acronym SLAP, but remember the SLAP means superior labrum tear anterior to posterior. Oh, okay, that makes a little bit more sense. And then panlabral. Pan in Latin means all. So the whole darn thing is torn and it's all damaged in there, okay? So just understand that we don't have to be so scared of terms. When was the last time you talked with a patient about their MRI or their x-ray findings and they pull out this report and they're like, I don't know what this means. It's a foreign language, and it is a foreign language. but we interpret that stuff for our patients. So make sure it's comfortable for you, all right? Now, getting further into treatment here. You can see the example of a cold laser being applied to somebody. You can see the taping. You can see someone doing some nice muscle work and some good rehab. Just realize that you and your practice are going to choose what you want to do on this. And every year you're in practice, you get a little bit more refined in how you do things. I have used laser for over 10 years now. It is fantastic stuff, but I don't need to tell you because a lot of you have come off the fence in recent years and you've got a laser in your office now. But ultrasound works. Stim works, interferential works, it all works. You just got to use what you want to use, all right? Now we're going to go through some adjustments now, and I'll show you a little bit about taping. So now with the shoulder adjustments, here's what I want you to be aware of. There are always options that you have, and it does not matter who you learn from, me, other extremity teachers that are out in our field that are well known. We all have ideas, but guess what? You are treating the patients. You have to choose the techniques that work for you. It doesn't matter what I think or anybody else, as long as it works for you. So when I go through all these things, it's meant to show you options so that you can use them to have more ammunition to fight the subluxation battle with, all right? That's all it is. It's not to tell you, you got to do this because this is the best and only way to do this. If practice has taught us all one thing in all these years is that we learn to add more adjustments to our armament and it makes us better doctors to help more patients. That's what we want, to help as many people as possible in the world. Now, we can do manual, drop table, or instrument adjusting. All right, I want you to make sure that when you do manual adjustments, that you are comfortable and your patient is very comfortable. Look at Dr. Handsome right there. He's got this pretty classic maneuver we all learned in school. And guess what? That's fine. I don't find it particularly comfortable having it done on me or doing it, but that doesn't mean that it doesn't work for you, all right? So let's just check this out. This is my shoulder protocol, and I'm really excited to show you. You guys are the first ones to see this. I just made a recent video on this, so here we go. Oh my gosh, let's go back.
We're going to talk about the shoulders, and we're going to talk about how we kind of do a quick assessment and go through and adjust the shoulders using the drop table protocol. So when we approach our patient, I usually like to have them seated so that they can be sitting and semi-relaxed. And I'm going to take my hands, and I'm literally going to come up to the shoulders, do a little palpation. One thing I want you to notice is most of us out there have shoulders that are forward like this. Most of you and your patients have shoulders that are a little bit forward like this. Even when they're sitting, people's shoulders are a little forward. Now, this is something that is very common in our society. They're working this way, they're sleeping on their side. So most of what I'm looking for is when I put my hands on here is I feel the front of the humeral bones, of the humerus bones, and I can compare side to side. And when you do this on your patient, you can pretty much feel which side is sticking forward more than the other. Sometimes if the patient is having bilateral shoulder issues, you can feel both humeral heads forward. So it almost seems like, wow, they're symmetrical, but they both feel like they're poking out a little bit. Often, when a patient's humerus is forward, when we put our hands on them, we can feel tenderness and pain as we push gently right into the front of that humeral head. You can feel that it's already shifted out, all right? Now, I'm going to do a little bit of a muscle test. This shows the patient what's going on with their own shoulder, gives us a baseline before we adjust them. So I'm going to move over here, and we're going to just take this one here. And would you please take your arm and push up for me when I tell you to? Push up. Okay, so push up as hard as you can. Her arm is already weak, all right? So let's try this one too. Hold here and push upwards. Now, push up as hard as you can. Okay, good. So we're actually going to fix both of her shoulders because both of them seem like they're a little shifted, all right? So let's have you lie on your back here. I'm going to show you both sides shoulder adjustments on the drop table. This drop table protocol, something that I use on just about every single patient that will need this kind of work. So I'm just going to make sure that the table is set. And I'm going to walk through these joints with you. So first is the glenohumeral joint. It's called anterior inferior, AI shoulder. I'll take my thumbs. I'll find the front of her humerus head. And this is a very tender area to contact. Most people are very sore in here, but I can feel it. So I'm going to take care of my inferior component first by going I to S. And I just caught the jaw piece and I thrust. Now, I'm going to take care of the superiority, the A to P part by just moving her arm a little bit. So I'm going straight A to P at about a 90-degree angle. My thumbs have come off the humeral head just a tad to find the other part of it that's a little bit higher, but I'm still on the humeral head there. And this gets very sore for some patients. And then I'm going to go straight A to P. All right, so first thing I did on there was I to S, then A to P. Now I'm going to come off and go to the sternoclavicular joint, which is the end of the clavicle right there. So my thumb is on the distal clavicle. Both my thumbs are, her arm is coming up a little bit higher, so I can go with this S to I line of drive. And then I'm going to go thrust right down on her distal clavicle. So there are two of the joints right there. Now I'm going to move over to the first rib. The first rib is sitting right in here. That first rib tends to go superior. So I'm just going to take a couple thumbs. So right below her clavicle on that first rib here, I'm just going to go press S to I. And finally, right in here, the sternoclavicular joint, I'm going to go Sam to pill, which means I'm going this way with my line of drive. So I can just set up right in here like this. And I'm going to thrust across just like that. And then for the ribs in the top part where I usually get have gone pretty much superior. So I can just put my knife edge right along here and then just adjust like this, all right? So I've gone through, I'm gonna go to the other side just so you can see on both sides. I'm gonna bring her arm up. Again, find that humeral head right in here. I can feel how sore and how tight it is in there. So I'm gonna go I to S first. Remember, because it's an AI humerus, so I to S. Anterior to posterior. My thumbs are still on that humeral head. I go S to I on the very distal clavicle, which I feel right over here. Her clavicle is coming along, and I've got it right there. And her arm is, see how her arm is up at an angle, just like I did on the other side. S to I. And then first rib, right below the clavicle and proximal here. And then Sam to pill on the SC joint going across 45 degrees. Lastly, the ribs. So the rib heads, S to I on the ribs. Remember, you can take the ribs further. Like if I come down in through here, I can go A to P on the ribs, but only if somebody really needs it. I try to just do a little bit of work on the front of the chest, especially if it's a female patient. If I don't need to do some of those other ones, I'll just skip those, all right? But you can come in here and do a knife edge right on the A to P for the rest of the ribs. All right, let's have you sit back up and we'll do that muscle test on you again. There you go. So let's go ahead and push up. Good. And push. Good. In fact, let's bring it down even a little bit more. There you go, 90 degrees, push up. Now, the patient will see the post-muscle test being stronger. And then when you go back up in here and do your palpation again, you'll actually feel that the front of the humerus and the humeral heads are actually shifted back a little bit. It's a lot easier to feel that it's more relaxed.
All right. So there is my protocol. If you like it, it's right there for you. It's just a roadmap to remember how we can do this so that we don't miss any of the steps. And quite honestly, once you start doing this, you're going to remember. Yes, I showed you the drop table because I do the drop table primarily on people's shoulders. Can you do manual? We already talked about this. Of course you can do manual. And I'm not here to tell you what you're doing is wrong if you're already doing it that way, but I want to give you more options. This drop table protocol is ridiculously comfortable for people. But Kevin, I don't have a drop table. Okay, maybe you have a portable speeder board or something of that nature that you can use as a portable drop piece, all right? But for those of you that do have those drop tables, and I know a lot of you have them, this is a great way to treat your patients, okay? I've got pictures, again, that are outlining what I just showed you, but it should be pretty fresh in your mind, okay? But these pictures are going over the different directions that I was standing and getting onto those joints so that it makes it a very complete picture on what's going on. I just want to make sure that you are aware of how the ribs and all the on the hand placements and all that stuff all right? Kind of couple different angles, all right? Now with the taping, for the first time, I'm able to show you my taping on a webinar because I did a video on this.
Okay, now we're going to talk about using elastic sports tape to support the shoulder once you've made your adjustments. The taping for the shoulder has been something that I've done for so many years. Patients actually really enjoy it, and it helps to babysit them when they leave the office, because a lot of people will go out and they'll feel better, so they'll start doing housework, or they'll get on the computer for a while, or they do some crazy stuff. So I'm going to take a piece of 2-inch tape, and I obviously could kind of measure it to just kind of see how big the shoulder area was on the patient. But I rip my tape and I just anchor my one piece right down here like this. And I'm going to go about mid-deltoid around that area. I'm just going to pull that piece up to here and let it settle down. Now remember, coming off the backing, most elastic tapes have about 10 to 15% stretch. All right, in this case with rock tape, it definitely does have 10 to 15% stretch. Sometimes it's 15 to 20% stretch, depending on which size of the tape you're using. So I'm going to come from right here in the front for the second piece, right around the front of the humerus, the humeral head. I can feel it behind there. And I'm just going to gently pull that back. Gently pull it back, and I'm not even really pulling very hard. Everybody always wants to know how hard you pull the tape or how tight is it. How's that feel? Is that fairly comfortable? Mm-hmm. It'll disappear after a little bit. This is a tape job that I do on everybody's shoulders. Remember, we fixed both of her, so I would tape the other side as well. But this is what it looks like, and it's easily reproducible, and it encourages the patients to buy tape from you before they leave the office.
All right, so here's pictures of the tape job again. I have been doing this tape job for 20 plus years. It's so solid and so easy, and the patients will buy tape from you, even though they can get it from Amazon. If you have tape sitting in your office, they'll just get it because it's there, all right? But there are 2-inch strips that I put on, and I also, it's hardly any pre-stress on there, all right? Now, I have a little bit of time still. I want to show you this one main manual move that I do. So just sit there for a second and see what you think.
We're going to go over my favorite manual shoulder adjustment. I don't do a lot of manual shoulder moves because the drop table pretty much takes care of the shoulders for me. But on a fairly regular basis, I like to get in there and really open up the shoulder and get some audibles. And the patients feel really great when their shoulders kind of shift on them. So let me show you this one shoulder move that I really enjoy doing. That's a manual move. So the patient I'm going to show you sitting first. This is a supine move, but I'm going to show you the setup first, kind of see it can get a little complicated. That's why I wanted to do it sitting first. The patient is going to have their arm across to their shoulder like this. All right, that's the first step. Now, I want to point out something. Her shoulder joints that we know of, they're all sitting in through these areas. So what I'm going to end up doing is taking my hand, I'm going to come underneath here like this. Now, let me point out something. The butt of my hand here is going to go on the SC joint, okay, while my fingers are going to come over here to the AC joint. And my thumb web's going to be here, helping me to get the glenohumeral. So I'll get all three of these major joints in here, and with this hand, but make sure I show that. Okay, so here comes my hypothenar on the SC joint. There are my fingers coming over here to get the AC, and there's my thumb web right in here to cover the glenohumeral. Good. So now you've got this hand sitting there. All right. My other hand is going to be right here. My thenar and hypothenar, if you feel here, there's the spinous processes, and there are the transverse. There are the rib heads. The rib heads are also out of alignment, and that's what we want to deal with when shoulders are out. So now what I can do is, at the same time that I'm taking the contact here, I can take these guys, I can put them on the rib heads, multiple rib heads here, and I can traction down, because most of these ribs have gone S to I. So I traction down while I strap the shoulder here. And my adjustment really is going to be this kind of a move. See my hands, how these are pre-stressing down and this one's pre-stressing up, okay? So let me show you how I actually execute this. So let's have you lay on your back, please. Let's give you a nice pillow here so you can lay on there. Here we go again. arm comes across. My hands come right in through here, right? Now, but before I do that, I have to roll her and get this one placed right where I showed you before. There's my hypothenar and thenar right on those rib heads underneath there. So now, as my arm sets in like this, watch my shoulder, how I chop her elbow right underneath there. So now, remember I told you, this comes down, this comes up, and then when my body thrusts down, I get a really comfortable set on her, and I can get multiple noises from those bones shifting, the ribs and the shoulder, all right? So one last time, roll her over like this. Do it like this, take a breath in, and relax. Good. Okay? All right, so that's how we execute that move. I just wanted to make sure I showed you so you could understand how to do a nice, relatively comfortable shoulder maneuver.
All righty. We got some shoulder exercises that we can do. There's a ton of them. You know, honestly, the patients really do look up a lot of the stuff on Google these days. They're all, but you have a few of them that you want to show them. I think a lot of it has to do with also helping them to realize that sleeping on their side is not the best position that they can be sleeping in, or making sure they have a good pillow if they're going to sleep on their side at your, you know, a pillow that you might suggest or that you might be able to point them towards. Sometimes I actually have patients come and bring their own pillows to me so I can analyze them for them. But okay, there's some other rehab type things for strengthening. I did want to show you that with elastic tubing, you can do some elastic tubing exercises that are specific for the rotator cuff. I only give a few of these, but you know, this is horizontal abduction. This is horizontal adduction. This is obviously plain abduction. This is adduction. And then you have extension, you have flexion, and external rotation, and internal. And that covers all of your degrees of motion. And you know, this particular type of elastic tubing, you know, elastic tubing in general is just great for this because the patients can take it with them and they have it everywhere. That they can take it to work, they can have it at home, and it's portable for vacation, you know. So this really follows them around, and it's just a matter of them getting this done if they want to have improvement for their shoulder. So I want to make sure that I have given you a way to contact me if you have any questions, because I love this stuff. I have loved teaching this stuff for years now, and I've gotten a lot more refined with how I present this information to you. I try to make it as succinct as I can, but shoulders do not have to be complicated. You don't have to read a really long textbook or have a 12-day seminar on this. We've gone over this in an hour. And yeah, if you were in front of me and you're at one of my real seminars where I'm doing the hands-on, we are workshopping this and we are kind of talking about questions in some of your cases, but this is it, man. Ladies and gentlemen, this is it. I mean, this doesn't have to be complicated. So I hope you've enjoyed it. And please let Christy know what you thought, because she's always trying to bring you awesome content. I have seen quite a few of the webinars that she's offered you, and I'm amazed at the variety of titles and speakers that she has. So just let her and Dr. Foxworth know what's going on. And I certainly appreciate being here with you. And I thank you for giving me an hour of your time.
Well, I hope y'all enjoyed that presentation from Dr. Wong. If you have any questions for him, either today or you're watching the recording, just email me, Christy at ChiroHealthUSA. I will forward those to him. I'm so sorry y'all are looking at my messy desk. But forgive me. So just forward those emails to me. I will get them to Kevin. We'll get those answers. We'll share them back with you. Just wanted to let y'all know what is coming up in the coming weeks for webinars. We've got how to build the largest practice in your city by working with medical doctors, and that is with Dr. Aram Tahir. She is like one of my favorite speakers. I have spoken with her at Parker. We are at a lot of the same events. She did a TED Talk. She is just phenomenal, such a dynamic speaker, and I absolutely love her. Then we're having a new speaker who's going to be on the webinar series, Dr. Rosemary Bachansky. And oh my gosh, if you have never heard her speak, she is so funny. I always laugh when I hear Rosemary. She is phenomenal, and she's going to be talking about the 4 pillars of practice, because it's not just about the clinical side of what we're doing. It's also about building that business. And then we're going to talk about chiropractic in the military. And there are so many amazing things that are going on that, just are not getting out there about the work that is being done for chiropractic in the military, things that are a long time in the making. And I am so excited that Baron Hoig and Dr. Tim Novelli are going to be here. If their names sound familiar, Baron is a national speaker. Dr. Tim Novelli founded the Patriot Project, which is phenomenal. It's a great nonprofit organization that you can get involved in if you want to be helping to treat active military personnel. I'm also a volunteer. I'll just show up and tell you that, and just preface that and say I'm a volunteer with the Patriot Project, because you just cannot help want to get involved. And then we're going to be talking about the Cures Act overview, because there's a lot of misinformation out there about what's going on. And Mr. Mark Abla is going to be here, and he is the executive director for the Illinois Chiropractic Society. He has spent months and months doing research with attorneys and figuring out what it is that we need to know in the chiropractic profession and how this impacts you in your practice stuff. And if you kind of want to like a heads up, like kind of like an overview, email me and say, hey, send me that info about the Cures Act. If you just want to, like I said, there's a great podcast I can send you that was done on TikTok with Brad Cost and Dr. Jay Greenstein. That is phenomenal, where they interview Mark about what to expect and the benefits to the chiropractic profession. So if you just wanted to hear about it a little earlier, let me know, email me. We have a lot of great info, a lot of great speakers that are coming up in the future. Again, always email me if you have a suggestion for a speaker or topic you would like to see addressed. And I'm excited to announce that in the coming months, we're also going to be coming out with a podcast, because so many of y'all are treating patients and want the flexibility of being able to listen to something quick and concise in about 30 minutes. And so we are going to be coming out with a podcast in the next couple of months. We will still have webinars, so we're not getting rid of that. There just may not be as many every single week, but we will be having a weekly podcast that's going to be coming out to address all kinds of issues. We're also going to talk about patient outcomes, where we have patients and doctors on here talking about how chiropractic benefited them. We're working with several people to get specific athletes to talk about how it has helped them, because it's going to be a great thing for you to share with your patients as well. But we're still going to address all the stuff that has to go with day-to-day practice. So we're not going to be losing any of that. And again, we're not losing the webinar series. We're just going to be scaling it back a little bit in the next couple of months. So while we're launching that podcast. So again, whatever you want to hear about, tell me about it. I am here. Thank you so much for being here today. I hope you have a phenomenal rest of your week, an amazing day. And I will see y'all next week, same time, same place. Bye, y'all.